to examine the effect of the 1.5-year intensive systematic dietary manipulation, ISDM, in stable patients with IC. Study included 40 female patients. We developed an original IC diet, including food restriction, and 30 patients with ISDM, and 10 patients without intensive instructions. This is restricted food. And the parameters: O'Leary Sand Symptom and Problem Index, OSSI, OSPI, urgency, bladder pelvic pain, visual analog scale, BAS, and QOL index were evaluated. No significant difference was observed in the background of both groups at the start of DM. ISDM showed improvement in all parameters in the first 3 months, and continuous efficacy maintained at 1 and 1.5 years. In IDM, it means non-intensive dietary manipulation showed no significant improvement in the first 3 months or at 1 year. Moreover, a worsening trend was observed in all parameters at 1.5 years. Also, 6 patients in ISDM who received amitriptyline could reduce the dose by 1 year after treatment. ISDM relieves various symptoms of IC and QOL over the long term, and may also reduce the need for other treatments. Thank you for your attention.
Questions from the floor? So what was, you say this was an original diet. What was original about it? It looks as though many of the principles in here are similar to what have been proposed by others.
This menu is very similar to the dietary diabetic patient conversion.
Okay, very similar. And I guess I'd be curious if we know that this diet may reduce histamine stool levels. That's, I know, not a question you can answer, but I'm wondering whether the other presenter, I think I heard her say that it's dietary controlled, so I'm just curious whether this would work on the histamine too. We can talk offline. Go ahead.
Beth Shelley, physio from the U.S. Wondering how you diagnosed IC, and did you separate out people who have Hunter's lesions or not, and maybe were some of your patients who just have painful bladder syndrome? How was the diagnosis?
In Japan, the diagnosis uses a cystoscopy by outpatients and local anesthesia, and examine the hydrodystension, mild hydrodystension, and diagnose as a Hana lesion or any other.
Okay, thank you.
Okay, understand? Thank you.
Thanks for your presentation, because I think this is a strong message about the management of such complex group of patients, in which we focus mainly on the treatment of therapy, of medical or pharmaceutical approach, and we sometimes forgot one of the more important aspects. Also in guidelines is not so focus specifically in how much the foods interfere with the flares in such patients. Thank you.
Thank you.
I just wonder, in the 2 groups of patients, did the group with more intensive dietary manipulation, did they see the provider more than the other group did?
The other group indicated the mild overall disease of IC, and not diet instructions.
In the intensive group, did they come back to the dietitian or to the provider more often during this 1.5 years than the other group? I'm trying to get to the same question I had on the last paper. Is this a seeing the provider effect rather than an effect of the therapy itself?
Yeah. ISDM has a strict diet menu, but NIDM not itself. But mild education about the LC, this is already to avoid the foods. Mild education was performed. Understand?
Okay.
Yeah.
Thank you.